Hello, everyone. Just for the sake of time, we're going to go ahead and get started today. Thank you all so much for joining our session today. I'm fortunate enough to be co-presenting with my phenomenal colleagues from Shift Health Accelerator. In our positionality to healthcare, we focus on elevating community-driven and community-led change in sectors like healthcare, for example, because of our own personal lived experiences and the experiences of those close to us. And secondly, we actively interrogate what it means to be community-led, anti-racist, and equitable to ensure that the most affected communities can actually say themselves that they benefit from a community-driven health initiative. So with that, I would love for my colleagues to introduce themselves by just stating your name and your role with Shift Health Accelerator. I can pass it to Sonia first.
Great. Thanks, Artair. Hello, everyone. It's good to be with you all. I'm Sonia Sarkar. I'm based in Baltimore, the land of the Piscataway people, and I am a member of the Shift Health Accelerator leadership team, where I oversee some of our programs related to healthcare accountability, which we'll be talking about a little bit later. And we're all looking forward to the discussion with you. So I'll pass it to Lisa.
Hello, everybody. I'm Lisa Richardson. I'm also a member of the Shift leadership team based in New Orleans. And in my work with Shift, I do a lot of our focus on equitable evaluation and community-led change. It's really a pleasure to be with you. Jen?
Good morning, everyone. My name is Jen Lewis-Walden. I'm also on the leadership team of Shift Health Accelerator, and I'm based in El Sobrante in the San Francisco Bay Area. Excited to be here.
Great. I think there are a few housekeeping things. So here are some of the agreements for a safe and brave meeting space that I'm pretty sure a lot of you have seen throughout the conference. I'll give you a moment just to review those. Okay. And we definitely want you to engage with us in this conversation. We are going to be throwing a lot at you, but we want to, hear your thoughts and hear your questions. We will have space at the end to engage in dialogue, but we would love for you to engage in the meeting as well. Okay, so I'm going to really start off with some previous work. I think when we discuss the tension between anti-racism, technology, and social determinants of health, we're ultimately here to interrogate the perception of power and the actual fulfillment of power. So starting off, I'm looking at two workshops that had about 40 people total who are actively engaged in the social needs space. I was able to really partner with two colleagues, Stacey Thomas from Health Please and Ray Faustino from Aluma, to really ask folks about their perception of how power, money, and data flows with social needs and social needs interventions. So through this exercise, looking at this kind of diagram that looks at money, participants shared that money flows from funders, which could be health systems, philanthropy, government agencies, and private equity, to technology vendors, and that technology vendors are typically for-profit companies that provide resource and referral technology tools. To a lesser extent, they said money also flows from community members to healthcare systems as payments for healthcare, and to large and small community-based organizations as donations. When we look at data, and the reason why we looked at data is that in a technology-driven world, data has become a very valuable commodity, and anything that has value within a system can create inequity. And so our workshop found that data primarily flowed out from community members into technology vendors, healthcare systems, data analytic organizations, and small and large CBOs. Actually, one of the participants shared that health systems and health plan providers are collecting data on individuals. They're using that data to then identify how much health insurance they provide should cost for different groups based on different characteristics associated with those groups. And then lastly, looking at power, we know that money, data, and power are inextricably linked, but participants specifically focused on how most of the power in the ecosystem is flowing out from community members and how that power goes to healthcare systems, government agencies, and to technology vendors. So with the Shift Health Accelerator team, we were really thinking through how do these perceptions fit in a framework. And I was definitely privileged enough to work with some great folks at 211 San Diego, as well as some folks from Health Leads to really think through how do systems map upon, I guess, some type of power structure. This is a framework that I know has been discussed before, but we're briefly going to talk about how that's fitting into how we think through anti-racism and technology. So essentially, we try to understand the trajectory from moving from what we saw as a system focused on exploitation to one focused on liberation. And there are three things that we learned as we began to map these systems across this plane that caused us to look at who benefits from the system, are there strategies to address harm that may come up, and then what is the impact on the most oppressed communities? So as we were looking through this, we saw that there was more of a straight line path if the institutional priorities were the main focus. And then at best, you can get to an allied design system which focuses on listening to feedback to support institutional goals and objectives. We saw that in order for you to get to an equity and power system, that there's a need to really embark on an anti-racism journey that's not linear, that interrogates positionality and power to hopefully shift power to the community. And then we also noticed that for us to think through liberation, we have to think through partnership and also think through what it takes to dismantle forces of oppression that often comes across or comes against marginalized communities. So we knew that our goal was dismantling unjust systems. At Shift, we were really trying to interrogate what creates this limiting barrier? Like, what is that? And our collective response was just white supremacy. But we were wanting to know, how do we bring that to life? What does that look like? And we were doing a literature review. Rosalind Chow had this great framework that looked at backlash to racial equity efforts in professional and HR spaces. And in our work, we thought that we could deploy that type of model onto this graph or onto this framework. And so we began to look at white supremacy really coming in the form of narratives that deny, distance, and distort. And we'll talk about that a little later on. So how this shows up in research is simply the fact that research often gets to distinguish and denote what is of value. And it's not like health systems have not been investing in social needs and social determinants of health before, but there's been a positive view of that investment. And when we talk about positivist view, we're really looking at what is the evaluation seeking to do. So oftentimes we see an investment into the community coming from community benefit. And those, with that investment, the value case is really dependent on goals or metrics established by the healthcare system. And in this study, we saw that there was no association between total community benefit spending and food insecurity or medication adherence for diabetes. So there are a couple of things that we were thinking through when we see studies like this. So seeing that there's not a statistically significant association with adherence to diabetes and hypertension, led us to question who set diabetes and hypertension medication as a metric of success and why. And if community benefit does not yield the return on investment, or I guess, yeah, the metric that's desired by the time dictated by researchers or healthcare leadership, what happens to that investment? So we contrast that to what we see within the social determinants of health space currently. So we saw such an influx of investment into social determinants of health. A lot of this was coming from the accountable health community's introduction through CMS. And we're also seeing that there is a shift in cost structure where social determinants of health became between 40 to 50% of the Medicare or Medicaid cost structure. This leads to health systems and others investing within social determinants of health. A study called For Profit but Socially Determined showed that $2.5 billion of health system funds were invested in social determinants of health. So we started to look at where does that money go? So with this investment structure, this article showed that 58 companies received $2.4 billion in funding. These 58 companies have a total valuation of $18.5 billion, and they're mostly located in California, New York, Massachusetts, and Illinois. What was really surprising was that out of those 58, 5 companies have a total valuation between $100 million and $1 billion. And actually, one social determinants of health technology company has a valuation of $1 billion. So what we're really trying to understand is why is funding concentrated in a few in a few companies and actually a few places geographically? When we think geographically, what does the investment structure say about the SDOH sector landscape? How does this funding structure correspond with anti-racism and equity? And then ultimately, because of the work that we're doing, how would the community respond to this investment structure? And so that is why we feel like we have to have a critical lens associated with the work that we're doing. And again, what do I mean by that? Moving from a positivist position where we are really looking at a sample and we're trying to use that research to give some kind of generalization of a population, where we're focusing on cause and effect. And ultimately, the people who are doing the inquiry are researchers, to then moving to a lens where we're actively interrogating and seeking to transform the social, political, economic forces that create so much oppression to the groups that we're studying. And even more so, we were really interested in understanding how do we shift to partnership and even ultimately leadership, where the folks who are experiencing the oppression have the power and the agency to actually do the inquiry and the research on the lived experience that people are doing the research on them anyway. And so that caused us to go back to the framing that we talked about a little while ago, where we were wanting to interrogate the narratives that prevent us from moving from this positivist lens to the critical lens. And so we're doing a deeper dive now of understanding what does deny mean, what does distance mean, and what does distort mean within this sector. So I'm going to pass it to Lisa to really give us some insight on what denying looks like within the social determinants of health space.
Thank you, Artair. Thank you for laying that really important foundation. I do want to just preface my examples, my personal examples, by saying I've worked for 15 years in a community-based public health institution. And I have, as a researcher and an advocate, and so I'm bringing multiple lenses to this discussion. And through my work, I have worked on state and national initiatives that are focused on maternal and child health. And I'm keenly aware of the statistics that many of us on this call are familiar with, that Black women in the United States are 3 to 4 times more likely to experience pregnancy-related death than white women. As a social scientist and a public health practitioner, I see the ways that historical, social, and racially biased realities contribute to these outcomes. But I also notice that the realities of structural racism are rarely discussed as we begin to develop interventions, particularly ones that focus on technology. So just to lay a foundation by what I mean when I'm referring to structural racism, I'm referring to the totality of ways that societies foster racial and ethnic health inequities through mutually reinforcing socio-ecologic systems. And those systems include housing, education, employment, healthcare, and beyond. So as I look at the field in the MCH world that I'm a part of, the maternal and child health world I'm a part of, I see that there are some technological responses to the Black maternal health crisis that I alluded to with that one statistic that I want to lift up in this discussion when we're talking about denying structural racism. On one hand, there are a growing number of technology platforms that are described as end-to-end maternal health that is more accessible, connected, and personalized. And these technologies use connected devices, telemedicine, mobile apps, and a variety of these sorts of tools. And the goal is to tackle key challenges in pregnancy. The selling points of these technology platforms is that they are supposed to give the end user or the birthing person more ability to monitor their own pregnancy and make decisions about their care. And they also intentionally cut down on the frequency of in-person visits for a birthing person who's with a clinical provider. So that's one example. At the same time, there are a growing number of initiatives in the era of COVID-19 that are seeking to understand the effects of the pandemic on birthing people during and after pregnancy. And around the country, many birth registries have been created, and they began by enrolling women who were exposed to the virus at some point in their pregnancy and are tracking women's outcomes over time. And the stated goal of these registries is to examine the risks of COVID-19 infection to pregnant women and their associated health outcomes for birthing person and child, and ultimately to inform clinical and social interventions and in ways that reduce disparities. And to be candid, I am a part of one of these birth registries in my home state of Louisiana. And I'm actively involved. I'm on the leadership team of a community-based public health organization. I collaborate with birth workers such as doulas and midwives. I serve birthing families. So my perspectives are very welcome in this birth registry space. But still, these birth registries remain dependent on technology because they're all constructed around electronic health records. And what's in those health records, the data that is being looked at are things like demographics, healthcare encounters, labs, prescriptions, procedures, and insurance type. These clinical data could be linked with socioeconomic realities and factors and community characteristics, but this information is not systematically reflected in electronic health records, so therefore it's left out of it.
No, you're not going to start that. I'm going to take you back downstairs. Shut it up.
I think somebody is off mute, if you don't mind. Sorry about that. So I offer these two examples to say, are there ways that these mobile apps, for example, could consolidate differential experiences that birthing people are having with income and education and access to adequate housing, disproportionate interactions with the carceral system, discriminatory experiences in healthcare. Can our technologies work to collect this information and build them into algorithms and latent class models that show structural racism as a multidimensional determinant of health? If they're not doing that, we are missing an opportunity to not only acknowledge the existence of structural racism as a key factor in health outcomes, but in using the technology to the best of its ability. I will also say, for the birth registry example, for me, this is very close to home. In my space where I'm working, I advocate consistently to have the voices, the lived experiences of birthing people in my community be included in the data that is a part of the registry. If we are not including that data, if we are not including those voices, I believe that the technology and the research methodologies are just reinforcing a denial of structural racism on the lived experience of people. And even so I offer these two examples for consideration, because as we design solutions that rely upon technology, if we're not careful, we can be replicating the extractive harms that are caused by documenting people's experiences, but not documenting them fully, such that the burden is placed on them, but the benefit is shifted to healthcare institutions, research outcomes, and ultimately perhaps the for-profit companies that run the technologies that we're using. I will stop there and pass the mic, as it were, on to Sonia, I believe, to talk a little bit more about ways that we might distort the realities of racist.
And I think you're up, actually. Oh, should I do distort, Artair?
Yeah, you can go ahead. Yeah.
Okay, all right. Thanks for that, Lisa. And yeah, Artair, really appreciate the framing. So a little bit about my background. I used to work at local health departments. Prior to that, I did patient advocacy in a nonprofit setting. And I wanted to talk about this idea of distorting, because I think it's particularly important, building on what Lisa was saying, in context where anti-racism has been named as a priority and as a process that institutions are going through. And yet, even within that, there are ways of the sort of core aspects of structural racism raising their head, particularly when it comes to data and research. So one example that I'll share is from my time in leadership in a health department setting here in Baltimore. This was in 2015, shortly after Freddie Gray had died, and there were lots of conversations happening in the city about police brutality, about the impacts of poverty and racism on health. And there seemed to be a really big opening around thinking about who is in the room when it comes to making decisions related to what health is, how health gets funded, and what kinds of outcomes are actually being looked at or measured when it relates to those things. So in the sort of period of time from 2015 through 2016, the city of Baltimore received a lot of federal funding and support, particularly to focus on the mental health of Black men in the city between the ages of 18 and 24. And as different types of institutions, healthcare institutions, universities, sort of the status quo institutions that typically sort of make decisions about health in a place, like Baltimore, they tend to be white-led, they tend to be quite academic and quite clinical, started to lay out what they saw as the standard for an evidence-based practice that focused on addressing trauma and mental health in Black communities. And not surprisingly, a lot of that was disconnected from the reality of what community organizations, activists, mobilizers, different people who are addressing mental health and trauma on the ground were actually engaging in and what they were seeing. So I was having a conversation one day at a town hall, and an older woman in her 70s came to me. She was from a neighborhood in West Baltimore, a grandmother, and she had been hosting a sort of multi-pronged mental health system and approach model at her house for over 50 years. She had thousands of different community members come through the space that she had set up, in which there were all kinds of different modalities that were being deployed that pulled from different types of ancestral traditions that looked at healing circles as a place for people to come and process their own experiences and to talk about trauma in a safe environment with people that they had relationships with. And her question to me was, how do I go through some sort of data training so that I can collect the data that's needed in order for my program to qualify for some of the funding that these academic institutions are naming as evidence-based. And for me, it was, I think a particular time for me to interrogate my own positionality in terms of what I was allowing to happen in the context of being a public official that's supposed to be accountable to community members, like the person that I was speaking to, but was spending the majority of my time with academic institutions that held a lot of power and hosted a lot of the dialogue in our communities. And I think what was so interesting about this conversation was actually the ways in which the inherent value of the sort of decades of qualitative data that had been collected in that setting, in that house, as well as the fact that people were coming into that program and leaving that program with significant impact on their own mental health and their ability to, really sort of bring forward other generations of solutions related to community trauma. All of that was being undervalued in favor of, a sort of more defined clinical and often sort of white defined approach to mental health. So I just share that because I think particularly as we think about distortion, there are many opportunities here to think about what counts as data. In what ways is my process actually honoring existing community definitions of success? How are we thinking about community narratives around what should be measured and what should be looked at? And are the research products, the actual sort of deliverables that are coming out of this process, are they things that are not just accessible to community, but are they things that community want and can use? And so how do we bring all of those components in, and how do we do that while also thinking about our own roles, our own institutional roles and community roles within that? So with that, I'll pass to Jen.
Great. Thank you, Sonia, and thanks, Lisa and Artair as well. I come to this work also from experience and multiple roles in the public sector, the nonprofit sector, and consulting roles in philanthropy, and really sort of interested in how multiple sectors are taking on the sort of new approaches to addressing structural racism through technology-informed interventions, and trying to parse out the ways that different sectors have different incentives and motivators that are driving a lot of the narratives that Lisa and Sonia mentioned. And for me, the space to bring in a couple of examples around the ways that institutions and individuals within those institutions, using their own positionality, are distancing the solutions, the metrics of success from the lived experience of those that are most impacted by structural racism. I think there's three ways that I want to highlight that institutions, through this work that I've seen, have distanced themselves from the lived experience of communities. One is that technology is being offered and created as in a narrative as the solution, rather than a tool for understanding opportunities. And so I've been involved in some of these interoperable data systems and referral platform systems through my work. And the technology often is centered as the opportunity to create the solution. And if it's framed as the solution, then all of the institutions, including the technology, are driven by the pressures to find quick solutions, to scale, to define an ROI on that technology, rather than interrogate the role of the technology to create opportunities to understand experiences. Lisa mentioned the sort of intersectional, dynamic lived experiences of communities. And so when technology is a solution, feels like a way that institutions are actively distancing from that lived experience. The next one in terms of a distancing tactic is utilizing CBOs and some of these referral platforms as a proxy for community lived experience. One, it takes a lot of time and trust building to have an understanding of what communities need and how success is measured. CBOs are often engaged, and usually these are the bigger CBOs, those that have the time and capacity to engage with a technology company, offered a free product and not offered the time, the money and full cost of how to actually implement these solutions or referral platforms within their organizations, and then often are doing the bidding for gathering additional CBOs within their networks to gain consent, to bring them on board. And so the sort of proxy nature of the CBO relationship and the power imbalances therein is another way of distancing. And then finally, as Sonia and Lisa and Artair have mentioned, how success is counted and measured as it relates to how the SDOH interventions are rolled out feels a particularly interesting case of how institutions are distancing from that lived experience of racism in communities. Framing people in terms of risk and risk scores, and then counting as a mechanism of the referrals rather than the health outcomes of communities. And so all of this together feels like opportunities to think about how distancing from how communities might define success, what health looks like in those communities, what power imbalances are there, are ways to think about the distancing mechanism within the referral platforms. I'll turn it back to Artair.
Thanks so much, you three. Right now, we wanted to just engage in discussion with you all, and one, see if you have questions that the four of us can take, or we have some discussion questions for you all, things that we want you to think about. I can read them so you can just take some time to ponder through them. The first thing that we're really thinking through, as I mentioned before, are the narratives or tactics. And so our question is, what narratives or tactics does your organization deploy in the context of, this could be evaluation and research, but it also can be in the interventions as well, that can be used to distort research or evaluation aims to institutional priorities over the community. So how are you looking to prioritize the institution, the groups that are in power, over what the community is really needing and what they need to thrive? And also just thinking through, what is your role or relationship to those tactics and narratives, and why are they so effective? Lastly, we would like for people to think through, how are you individually interrogating your positionality and seeking to push back against those narratives and tactics? What are some of the shifts you're leading internally to ensure shared power with the community? And again, this could be evaluation and research, it can be through intervention design. Just how are you pushing back on these narratives that seem to be very effective and preventing us from really being anti-racist within our work? I think there's some activity in the chat as well. That's from Sonia. Yes, feel free to drop us some questions as well. Any thoughts, any questions?
I have a question, if that's okay to ask out loud.
Oh, yeah.
Hi, my name is Deborah Brown. I'm a disease investigator for the Louisville Metro Health Department. And my question is, how do you, or have you had any success with using qualitative data to be the bigger influencer not against, but along with quantitative data?
That's a great question.
I'll take a
Do you want to go?
pass at responding, and then please open it to others. Thanks for that question, Deborah. I find if you are in epidemiology or in a sector that is heavily driven by quantitative data, it can feel a little bit like swimming upstream. But I think the value of always at least including some mixed methodological exploration is very powerful, and it can be a starting point in the sense that if there is a question, are we looking at the right metrics? Are we investigating? Are we using the right variables in our modeling? Gather people with lived experience that's very close to whatever the investigation that you're examining is, if it's a disease, if it's the experience of diabetes or hypertension or something like that. Gather people who've had that experience together and use qualitative methods to help tease out some things that you're not sure you're adequately capturing in your current models. And if nothing else, I find qualitative data is the best way to reality test. Is the model that I'm building really matching up with the lived experience or the solutions that I'm trying to get to? And people will tell you, well, they might surface things that you never considered putting into, your equations or your investigations. And so I think that there's always a way to use qualitative data and the voices of people with lived experience to inform inquiry. Now, it might be a slower process to change your system to build in spaces for that data being consistently collected and systematically analyzed, but you have to start somewhere. And so that's what I would offer as a suggestion, and I'd love to hear from others.
Yeah, one other thing that I would like to add, I completely agree with all of Lisa's points. Also thinking through how you can systematically collect qualitative data as you're going through the process of an intervention. So a lot of times when we think about qualitative data, it seems to happen more on the back end when we're looking at the evaluation of the intervention as a whole. And where I've seen qualitative data be really useful and maybe even circumventing some harms that may come up is really thinking through what are areas where you can do that qualitative work around processes that are happening within the intervention. A lot of times people use that as kind of getting feedback data on the intervention as a whole. But I think being able to have cycles where you collect the data, interrogate that data with your team, but also the community to understand what changes should happen with an intervention is really important, because a lot of times within research, when intervention is set or that program is set, the opportunities to change or alter that intervention decrease significantly, because you want the intervention to be the same so you can conduct the analysis that you desire to conduct. But I definitely think it's important to really think through how do we do that more at the forefront, like collecting that qualitative data where we can shape our interventions in a way that is more community accessible and reduces harm. Jen or Sonia, do y'all have anything that you want to add?
I'll just quickly add that I think, Artair, to your point about a positivist lens versus an interpretivist or a critical lens, particularly what I found with other researchers in academic settings, particularly as it relates to public health and social determinants of health, is that it's really useful to talk about what type of phenomenon we're trying to illuminate in the first place. That, I think oftentimes in a hospital or a space that's used to evaluating a clinical treatment or something that sort of lends itself perhaps a bit more to a positivist approach, taking a step back and saying, we're actually trying to look at how a bunch of different factors and forces relate to each other in the context of society. And so to do that, what is the approach? And then what is the type of data that we want to be using? So, sometimes starting there as well. Artair, it looks like we have another question in the chat about how one might define community. So do CHC providers and staff count as community? Is that still too removed? Some interesting power dynamics at play, but also seems key to involve multiple different communities. So how might we think about that as well?
Yeah, thanks for uplifting that. Who would like to start?
I can start. I mean, this is a question that we all think about a lot. I think, Arwen, to your question, one of the most sort of important things that we can do, I think, is define community for a specific context. So given what it is that is being talked about, often we try to look at who is most impacted by this inequity, who actually has the lived experience of the inequity and is closest to this issue. There's a lot of conversation right now about lived experience and really sort of thinking about what it means to engage folks with lived experience, given many of the other things that they have going on in their lives. And so I think there's that piece, but there's also really recognizing the different stakeholders inside of your institution and the relationships they may have to communities. So particularly at a lot of healthcare institutions, I think, as you may be alluding to here, oftentimes staff that are working at health centers may themselves be from the community and bring that perspective, even though they also wear an institutional hat. So just thinking about all of those different stakeholders and the relationships that they have to each other, I think is key. And we're also big proponents of not having a kind of broad, vague definition of community, but really defining it for a particular, for a particular institution, a set of initiatives, projects, etc.
I also, sorry, go ahead.
Go ahead, Artair.
No, Jen, you haven't, go ahead, you can go ahead.
I was just going to add on, Sonia, to what you were alluding to in terms of the different power dynamics that might exist within a community health center and community members. I think there's also a lens around how a community-based organization or a community health center might hold power as it relates to other institutional forces and really push back on some of the narratives or assumptions that are at play with bigger, whether it's public institutions or health systems or technology vendors that might have even more power to cause harm. And so that the power that community-based organizations and community health centers would have in order to really, particularly if it's a vendor client relationship, there is power in that space to push back and define the terms that are important through the lens of what the experience is through the health center and associated communities and clients and residents of those community health centers. So I think there's a power opportunity there as well.
I was just also going to add that one thing I've appreciated about our discussions as a group is just this continuous interrogation of if we're reaching the right community. And so I think a lot of times it's dictated by, Sonia, you mentioned this before, of who's the most marginalized, but also understanding what does increased agency look like for that group. From whatever initiative or intervention we want to see happen. And I really bring that up because I've really been pushed in understanding, especially deliverables that come from a health intervention or an initiative. If we're not producing products that community can use to increase their agency or to push for change, I think we have to question if we're reaching the right community, because our deliverables would not just be an article that is published within a journal. That wouldn't be the limit of our work. We would really have to think through what are the tools, what are community members wanting to see, and that would shape what type of products or deliverables that comes from this collaborative work, that would then hopefully facilitate, more liberation, more imagination for that marginalized community. So I just wanted to uplift that as conversation. I know that we have continuously to even help us to think through, are we reaching the right community, or are we reaching community? And is our work actually beneficial to the community as well?
Thanks for that, Artair. I just want to echo and say, simply put, I think holding the communities that we are working with as our main measure of accountability is very critical to making sure that we're on the right course. It feels like there might be a few more comments in the chat.
Yeah, I think we're coming close on time too. Yeah,
I'm wondering if we could maybe take one last question if there are any, and then we can talk a little bit about our learning network and how we're exploring some of these questions.
That sounds great. Do you see an additional question in the chat? I'm trying to go through them all, through all the comments. Thank you so much for even letting us know that this information is on the right track. So thanks for those comments.
Yeah, we're glad to know it resonates. Yeah, any last thoughts or questions? Okay.
I just want to say thank you all for this. I just happened to discover this looking for some professional development. And I was like, oh, this is what the stuff I've been thinking about. So thank you all for doing this, putting this presentation on. It lines up with what it's in my head, that I would like to see done in our community.
That's great to hear.
Thank you so much for sharing that. Super encouraged.
Yeah, it's great to have you all. Artair and I wanted to share just with this group a little bit about SHIFT's Healthcare Accountability Learning Network. So a lot of the work that SHIFT does is with community-based leaders. We are a distributed leadership network across the country and work with a number of folks who are engaged in all aspects of deeply sort of grassroots-based work around food systems, around reentry programs, around transportation, mental health, sort of whole gamut of social and structural determinants of health. And as SHIFT has worked with those community-based leaders, a lot of the feedback that we've received is that current health equity frames, although it's encouraging to see the language, it's encouraging to see the commitments, that these frames do not enable actual power sharing on the ground, that they haven't gone far enough in really doing the interrogation needed in order to move in that direction. And so the Healthcare Accountability Learning Network, which we just launched in the fall, we have some members of that network with us here in this call, is really intended to develop actual standards around healthcare accountability by specifically engaging healthcare leaders in political education. So this type of critique and analysis that we did a little bit of here in this session, bringing that into the healthcare leadership context. And one thing that we think is really unique about this particular network, I know we're all parts of lots of learning networks, including this one, is that we really try to center community leader expertise on these issues and hear directly from them on these frameworks, on these questions, on the different topics that they're covering. And then those that are signed up for the network are also committed to actually executing on a specific power shift project, so that by the end we can show that there was movement along that kind of the graph that Artair showed. How do we move beyond the kind of institutional context and into community context? So Artair, maybe I'll hand it to you just to talk a little bit about the getting involved.
Yeah, and we know that this work is going to require social movement. We know that we're going to be pushing against forces of power. And so we want to invite you all into that movement building work with us, where we can hold ourselves to a higher standard of how we interact, engage with the groups that we say that we want to help. And I just personally believe if we're seeing a disparity in funding the way that we're showing it, then I don't think the community will be pleased if they saw that as a sector. So we're really wanting people to come together with our community partners to really start to investigate roles and really thinking through what does it look like to develop these accountability standards. So we're going to host a convening in early 2023. And Sonia and I would love for you to email us, ask us questions about what that convening would entail. And we would love to have you part of that process in 2023, if not earlier. So we would love to stay in contact with you, and thank you so much for joining this presentation. Hope you have a great day.
Thank you all.